Okay, we'll go ahead and get started. Hello, everyone. Thank you for joining us today. I'm Linda Mitchell, CEO of Allergy and Asthma Network. Welcome to this afternoon's webinar. I'm honored to introduce Dr. Kimberly Blumenthal to tonight's webinar as speaker. We have a few housekeeping items that we will go over before we start. First, all participants will be on mute today for the webinar. We're going to be recording this webinar and we will post it on our website within about 24 hours. You can find all of our recorded webinars on our website. If you just go to our homepage, allergyasthmanetwork.org, and scroll down, you'll see the webinar recordings listed there. The webinar today will be about 1 hour in length, and that includes time at the end for questions and answers. We will take those questions and try to get to as many as we can, but you can put your questions in at any time as we proceed through the webinar. We have people monitoring the questions box, and if you have any other technical issues you want to ask about, you can either talk about it in chat or you can post it in the Q&A. The Advances webinar is ones that we do in partnership with the American College of Allergy, Asthma, and Immunology. The ACAAI offers CMEs for physicians for this webinar. If you are a member of the college, you can obtain CME through the member portal in the Advances on the Advances webinars. All attendees will be offered a certificate of attendance. No other continuing education credit is provided for this webinar. A few days after the webinar, you will receive an email with supplemental information about the topic and a link to download the certificate if you missed it during the webinar today. So we will try to add it in chat though. So let's get started. Today's topic is drug allergy, the importance of proactively addressing and delabeling antibiotic allergy. With the rise of drug-resistant organisms, proactive evaluation and delabeling of inaccurate antibiotic allergies is a key component of antibiotic stewardship and quality improvement. Unverified penicillin allergies can have an adverse consequence for public health as well as individual health. The goal of proactive penicillin allergy evaluations is to remove the label if the allergy is found to be untrue. It's my pleasure tonight to introduce our speaker, Dr. Kimberly Blumenthal. Dr. Blumenthal is an allergist, immunologist, and clinical researcher at Mass General Hospital and an associate professor of medicine at Harvard Medical School. She is the co-director of the Clinical Epidemiology Research Center and director of research in the Center for Drug and Vaccine Allergy. Dr. Blumenthal performs drug and vaccine allergy research, and Dr. Blumenthal is internationally recognized for identifying the morbidity and mortality associated with unverified penicillin allergy and creating innovative approaches to the evaluation of penicillin and cephalosporin antibiotic allergies in diverse patient settings. So thank you for being here today, Dr. Blumenthal. I'll turn it over to you.
Thank you so much for having me. I will share my screen. Okay. There we go. I will start with the disclosures is that I have done research with Thermo Fisher Scientific related to penicillin allergy, as well as write the some of the up-to-date sections related to the topic today. Our learning objectives are to describe the importance of proactive penicillin allergy evaluation and delabeling, to explain how to perform a penicillin allergy evaluation, and to identify the populations most at risk of an unverified penicillin allergy label. I'm very excited to talk to you today about this topic, which is very near and dear to my heart, and we will start with this idea of what is a penicillin allergy label and why we care. All right, so about 10% of the population reports an allergy to penicillin. And so this means about 32 million US adults. And so it's maybe not as common as it is in my waiting room. This is probably what my waiting room looks like, but at least 1 in 10 of patients in all waiting rooms around the country have a penicillin allergy label. And the more our patients are sick or interact with the healthcare system, actually this means that the frequency of penicillin allergy labels is even higher. So whereas it might be 1 in 10 in a primary care waiting room, in the hospital setting, it's 16%. And in a rehab setting, as you can see from this study, all the way up to 24%. This 24-25% has also been the same in cancer patients and other patients frequently accessing healthcare. And what we've known now for a while, and what we now are challenged to do in this next phase, is to verify penicillin allergy labels, because we know that just because you have a penicillin allergy label on your record does not mean you have a true allergy. This was actually a meta-analysis from 2017, years ago, that looked at all of the studies of our hospitalized patients, finding that 95% of them were not allergic. And so this was showing that those individuals, they were all skin tested, 1,391, and 95% were not accurately labeled. So there are penicillin allergy patients labeled correctly, but the vast majority are inaccurate. This is so important for improved patient care and population health, public health, because a penicillin allergy label is associated with getting different antibiotics just because of that allergy label. You get different antibiotics. They are more broad spectrum. They can be have higher side effect profiles. They can be broader spectrum so that you're at increased risk of MRSA or VRE, like resistant organisms. There's an increased risk of surgical site infections when somebody with a penicillin allergy label simply goes and has surgery because they're not getting the most effective surgical site infection prophylaxis drugs. There's an increased risk of C. diff because of not using targeted antibiotics, an increased risk of treatment failures, just changing the first line therapy just because of an allergy label, an increased risk of adverse events, and also all-cause mortality. And so we know as allergists that not all of these labels are true. And we also know that they have adverse consequences. And then finally, we learned in 2017 in this study that actually when we test patients for penicillin allergy and follow their antibiotic use afterwards, their antibiotic use changes. So we can, as allergists and in the allergy community, advocate for penicillin allergy assessment to quite literally change the antibiotic choice. So this was looking at 308 evaluated patients in the Kaiser Permanente health system versus 1,251 not evaluated. And this was what's called a matched cohort study. So it looked at the patients who had the allergist evaluation and then matched patients who didn't and looked at their antibiotic use and follow-up. And what you can see is that penicillin courses were 45% in the evaluated and only 2.5% in the not evaluated. And first generation cephalosporin courses, which includes some of the common antibiotics that are prescribed outpatient, like cephalexin or Keflex, as well as the inpatient cefazolin or Ancef, went from the evaluated is 32.5% and not evaluated was 20.5%. And both of those were statistically significant. So we know that if we test patients or evaluate and delabel patients, their antibiotic use changes favorably, more penicillins, more early generation cephalosporins. So because of all of these data, we actually now have a lot of professional organization and public health organization support for what we term penicillin allergy delabeling. So I like to say penicillin allergy evaluation with appropriate delabeling, because we can evaluate everyone who has a penicillin allergy label. Sometimes we confirm it, or sometimes we confirm immediate reactions or delayed reactions, but the vast majority are eligible for delabeling or removal of the penicillin allergy label in the electronic health record. We can see early on, there's a CDC support with, is it really a penicillin allergy? There's a Choosing Wisely campaign from the American Board of Internal Medicine that says don't overuse non-beta lactams and a history of patients with penicillin allergy labels. Antibiotic stewardship guidelines have now encouraged penicillin allergy as part of that. Recently, as we'll talk about in the pregnant population, the American College of Obstetrics and Gynecology now endorses penicillin allergy assessments. And then our organizations, the college, the academy, and infectious disease organizations, IDSA and SHEA, all support the idea of proactive penicillin allergy evaluation with appropriate delabeling. So it's interesting to think about why we would support a certain intervention or a deprescribing or a delabeling. And it's because we can improve clinical care, but it's also because this intervention is not costly. We did a study in 2017 where we looked at how costly it is to perform a penicillin allergy assessment. And we looked underneath here, you can see the different assumptions. So we changed the clinician from a medical doctor to a nurse practitioner. And we said, well, let's skip the skin test and just do a direct challenge. And that can really cost just $42 of real work. This method's called time-driven activity-based costing. That's the TDABC up there. So it's really like looking at how much work it would be for our clinic to do this, not how much we get reimbursed, which is actually higher than this, but how much it would cost our clinic to do penicillin allergy evaluation with no skin test and an NB provider would be $42. This is what we call the base case, this $202. This was with an MD clinician and doing one skin test followed by a one-step challenge if the skin test was negative. And then we have very different assumptions. Are you going to test also with ampicillin? Are you in a low demand clinic so that you have to mix up all of these things just for one patient and then you have to dispose of them? And so obviously it's more costly if you're disposing of things that are consumables. So we varied everything up to the highest situation. And in the highest situation, it was still only $369 for penicillin allergy evaluation, which is really not that much work for us all to put into our clinic. This is what's called a decision analysis that is used actually for most effectiveness studies. And what I set out to do with my colleagues was to look at, is it more cost effective to do a penicillin allergy evaluation or not? And that's what A versus B or 1 versus 2 is here. Patient gets a penicillin allergy test or doesn't get a penicillin allergy test. And this was with considering full testing with penicillin skin testing. And then each of these little, that's a decision node, that's the blue square, but then each of these green circles are like where probabilities get put. And that's how cost effectiveness analyses are done. And we ended up not being able to do a cost effectiveness analysis, and I'll explain why, because it was actually a cost saving intervention. Actually evaluating penicillin allergy largely saved money. So you can't study cost effectiveness, you study cost savings. So when we looked at these analyses, this shows many different scenarios. And I think that the most fun thing to do here is to let's look at the left where we did skin testing and drug challenge. And then if you can see the circles and triangles are inpatients and outpatients, and then the different colors are different regions. And this on the y-axis is showing the best strategy. So the number of simulations where testing saves money. So you can see all of them were above 50%. And in fact, the majority were saving money. So almost in every situation, you save money doing penicillin allergy skin testing followed by challenge. And then how much money do you save is like very dependent on our healthcare system, but it was at least $500 for inpatients and $2,745 for outpatients. And then if we look on the right, this is actually people, we skipped the penicillin skin test, went straight to a drug challenge, the two-step drug challenge, and you save even more money. And you save more money because there's not as much cost to the work involved with skin testing. And still you can see way above that 15%. So most of the time, you're really at 75%. So most of the time, it was just you saved money to do penicillin allergy evaluation in inpatients, in outpatients across Europe and across the United States. This is what I mentioned about doing cost effectiveness analyses. I was really interested in doing cost effectiveness analysis in penicillin allergy delabeling. I actually wrote my first grant on this. And this is the quadrant where cost effectiveness analyses are required. When you put in money to get more health, which makes sense. Like if you're going to look at a new diabetes medicine that's really expensive, how they decide to cost it out would be, you think about, well, how much money will it cost, but how much more health will I get? So you increase your health and you increase the cost. So this is where penicillin allergy is. This is in this other quadrant where you get more health, you get better antibiotic choices, less surgical infections, less C. diff, less antibiotic resistance, less treatment failures. You get all this better benefits of health. And it mostly is cost saving. So these are things we should just adopt. So that's why I'm here today, because we have to figure out how we can just adopt this. This is something we should all be doing. Okay, So now how do we do penicillin allergy evaluations? I want to start with the update to the recent practice parameters that were published in 2022. And these are a couple consensus-based statements from that. So the first is, we recommend against testing in patients with a history inconsistent with penicillin allergy, like a history of a headache, or family history of penicillin allergy. But a one-step amoxicillin challenge can be offered to patients who are anxious or request additional reassurance to accept the removal of a penicillin allergy label. This was a strong recommendation with moderate certainty evidence. So this is basically saying a lot of the people labeled might even not need to see an allergist, right? Because they have headache or family history, but those people should just be automatically delabeled. But if we can be helpful in the allergy community delabeling them, we can offer a one-step amoxicillin challenge for reassurance. And then the second consensus statement is, we suggest penicillin skin testing for patients with a history of anaphylaxis or recent reaction suspected to be IgE mediated. This is conditional and low quality evidence, so not as strong. But this is really where, of course, a lot of our work lies, because in somebody who recently had a reaction, it sounds like something that's IgE. This is when we need to skin test. And our colleagues probably from other from infectious disease or from pharmacy might not be comfortable learning or doing skin tests. So these are the patients that we absolutely need to see. A couple more penicillin allergy consensus statements. This is recommending against penicillin skin testing before the amoxicillin challenge in pediatric patients with a history of benign cutaneous reactions such as macular papular rashes and urticaria. The strength of the recommendation is strong and the certainty of evidence is moderate. So this is saying that our data in children is so strong that we should not need to do penicillin skin testing in the children with a history of benign cutaneous reactions. We can just go right to a direct challenge. And then the second one says, we suggest that direct amoxicillin challenge be considered in adults with distant and benign cutaneous reaction histories, such as macular papular rashes and urticaria. So this is saying those same reactions in the adults, those benign rashes, even urticaria, we can consider skipping skin testing and going straight to a direct amoxicillin challenge. You can see that in the pediatrics, this first line, strong and moderate, and in the adults, it's conditional and low. Okay, so penicillin skin testing has been around for ages, and it's recently enjoyed coming back in America. 2009 is when it came out with FDA approval of pre-pen. Now, internationally, full penicillin allergy kits are available, and we don't have that in the US. We just have pre-pen. And so some of these studies that show the sensitivity and specificity are ones that use all of the reagents that are available internationally. This was an international diagnostic study meta-analysis of 27 different studies that's looking at the sensitivity and specificity of the penicillin skin test. And the sensitivity is just about 31%, as you can see here, but the range quite long, from about 19% to about 46%. And the specificity is 96.8%, so about 97%, and the range from 94 to 98%. So it is a good test, the penicillin allergy skin test, but we have to remember that in the US, we don't have access to full testing, and that recent drug allergy practice parameters that we just reviewed just says that we don't always need to do full testing. So I want to talk about when we should do full testing and with everything. Now, this is a study that was published in 2019 where, and it was part of potentially getting us in America the full penicillin allergy skin testing kit. It was done in a multi-site in the US, and there were 63 positive subjects across these different sites. And one of the things that's most useful to see, so the first column is positive skin test result, the number of subjects. Then the second column, the middle column, is the percent of those with a positive skin test with this result. And then the third column is with a history of penicillin allergy out of the whole group. Okay, so what we can see is that if we only had pre-pen, this first row, we would not be able to pick up all of the true positives. it really only picked up 3% of those with a positive skin test and 0.4% of the allergies in this whole cohort. So what we need to do when we think somebody is allergic and we're going to choose to skin test is to try to skin test to as many reagents as possible. Now, minor determinant mixture is challenging to make for skin testing. But I want to point out that minor determinant mixture, MDM only, picks up 38%. So even though it was the minor determinant in this study, it was more common than major determinant or prepen. And amoxicillin was 6%. So what I do want to point out here is that we actually do skin test with ampicillin. Amoxicillin is not sterile, so we can't skin test with that and make that ourselves, but we skin test with ampicillin, hoping that we pick up these people. These people are positive to both MDM and amoxicillin, 13% of the positive subjects, 21% with a positive skin test results, and 3% of the allergy. So this was a study that really showed that when we're going to skin test, we should try to skin test with as many reagents as we can get our hands on, and the importance potentially of either making minor determinant mixture or skin testing with an amino penicillin ampicillin. I do want to point out that right now, our US hospitals largely don't have access to penicillin skin testing. So using methods of direct challenge or test doses is going to be a useful way to be able to spread delabeling and best antibiotic use into our acute settings like emergency rooms and hospitals. This was a survey we did in 2020 of 129 sites. And you can see that these are the ones offering penicillin skin testing. All hospitals, under half of them, had penicillin skin testing, and these were all US hospitals that had antibiotic stewardship programs participating in this certain survey. So it really does seem that even antibiotic stewardship savvy hospitals did not have access to penicillin skin testing. It was even lower at community hospitals, just 32% had access to penicillin skin testing. I want to bring to everyone's attention that we aren't, as allergists, the only ones who can learn to skin test. So of the places that had penicillin skin testing, of course, allergy immunology did the vast majority of it. But we have to encourage actually some collaboration given the 32 million labeled patients so that our infectious disease colleagues and pharmacists and nurses and other can learn to do penicillin skin testing when it's necessary as well. So 14% was the infectious disease, 12% was pharmacists. Some states don't let pharmacy do skin testing, and other states let that happen or have a provision for that to happen. Nurses, of course, and nurses do lots of testing in allergy clinics, and Pediatric's special testing service was another one. Okay, so who needs penicillin allergy testing? So now the practice parameter says that adults, you should consider going right to direct challenge. What's some of that data? So this is data from 2018 that had 3,299 adult and children patients summed. And the immediate onset positives, as you can see here, is just 1.3%. And the delayed onset positive was just 3.9%. And so this really, a lot of these were allergist-based studies. So this really says if an allergist says you're safe for direct challenge, you really are. Just 1.3% will react. That's a number I use a lot in my clinic when I'm consenting patients. And then I also use this 3.9%, this 4%, because I think that everyone should know that even though we clear it immediately in our clinics, about 2 to 4% of people will have a delayed onset positive, if not now in the next 24 to 48 hours, but also with a full course. This was a fantastic single site randomized controlled trial published in 2019 where it looked at just penicillin allergy labeled patients and identified those that they thought were low risk. So these are all the low risk, the 159. So those 159 right here, these guys were randomized. And they were randomized to getting a skin test or a graded challenge. And what is most interesting in this study is that if you choose low risk people, you will delabel more. 96% of these patients were delabeled with a graded challenge, a direct graded challenge. If you choose to skin test, 88% were delabeled. So this means that if you think somebody's low risk, we shouldn't do the skin testing because the skin test performs worse in low pretest probability patients. The skin test is better for those high pretest probability patients. So in these low risk patients, low pretest probability, going to direct challenge is the best thing. There was recently also a multinational randomized controlled trial that was set up as a non-inferiority study using a clinical decision rule called PenFast, and the scores less than 3. They ended up randomizing 382 low-risk patients by a PenFast score less than 3 to getting either skin testing followed by a challenge or a direct challenge. And what they found is that these groups, they were both so low risk. We should recognize that just 59% of the screen came in here and 86% of the eligible were part of this 382. But once they did this direct challenge or DC versus the skin test or ST, just one reaction in each group, 0.5%. So the risk difference, which is shown on that right column, is something that's not significant, which means this met their threshold for non-inferiority. Also, total immune-mediated adverse events, more than just these immediate immunologic challenges. The direct challenge group had 9 and the skin test had 10, and this risk difference was not significant. Okay, in the children, we should even be more aggressive about not skin testing because these are children and the data are better. This is one of the initial studies where 94% of kids passed a direct challenge. This one was 818 patients out of Canada. And one of the things that was really novel about this at the time is it really took all comers for the kids of allergy histories to amoxicillin. And they basically all got a drug challenge without skin testing, and 94% were not allergic. Since that time, there's now been 28 different studies, probably even more since then, because this was published 2023 as a meta-analysis of 28 studies. And I want to show the immediate or non-immediate, which is on the left, and then immediate only, which is here on the right. So a meta-analysis, of course, sums our risk of reactions across different studies. And the different studies are never the same, but it provides us some information that I tend to also use clinically. So when I think about your risk, if you're a kid, of having any reaction with direct challenge, I like to use this number right here, this 5.2%. So I'd say something like, well, across 28 studies, we can see that there's about a risk of 5.2% that there's a reaction either immediately or in the next 48 hours. And then also this is your risk of reaction in front of our face, which is really, really low, less than 1%, we can say. So many, many studies in children across the world have shown that there's safety and direct challenge for children. This is what we do, which is I just include because we don't update it with every single paper that is out there. But what we do is we updated it in 2019 to sort of bifurcate risk categories, thinking about who was low and who was high, so that across our whole group, everyone's doing the same thing and there is consistency in what is our skin test and what is our graded challenge or direct challenge. And so our high risk group are patients who had recent IgE-mediated reactions less than 5 years ago, cutaneous or systemic or prior positive skin testing. And those people will get skin testing to everything we have. We do not have minor determinant mixture, as I mentioned, but we do pre-pen, penicillin G, and ampicillin skin testing. And then if the skin test is negative, we do a one-step challenge. The people on the left, we bill them for their skin testing because you can't bill a one-step challenge of 60 minutes. Now, on the right, we have the lower risk category. These are cutaneous reactions, even if they're IgE more than 5 years ago, non-IgE cutaneous reactions, unknown reactions. And these patients, we do 2-step 30-minute challenge. And they get, we bill for just the challenge only. There is this little note here that just the allergy risk is about the reaction, but it's also about the host. This I have to think about all the time because we're at a major tertiary referral center. And so patients will come to us before a lung transplant, before a CABG and a valve, those, or if they're pregnant. I tend to consider all of these as high-risk patients, and I skin test them because it's gives me and the patient reassurance because they are higher risk hosts. So there have been recently these prediction models used to distinguish high versus low risk. So instead of just saying, this is my clinical experience, this is what we do at MGH Allergy, to say this is high risk or low risk, there have been large studies that use data to say this is high risk and this is not. And this is from a review article in 2021 that I put together. And I was trying to list out a few of the very common different prediction models that have been published. And this Trubiano et al. Is the PenFast one we had just reviewed. And I said, well, what are the consistent risks of high risk? And anaphylaxis, a history of anaphylaxis is consistent across all of the studies, as if you have to ask about anaphylaxis. And the other is the elapsed time since the reaction before the evaluation. So I use these in many different ways. I consider that my colleagues should always ask about anaphylaxis and the time since reaction for their risk stratification. Those are the two most important factors. Those are consistently them. I also think that we should use them in our own internal risk stratification, that patients with anaphylaxis or recent reactions are those that we should be skin testing. Whereas those who didn't have anaphylactic reactions or had been a long time since the reaction, we might not need to skin test. Okay. I want to review a little bit more about the PenFast clinical decision rule because we might be asked to lead it for a lot of different groups or our collaborative hospitals. It's very catchy and easy to use. And so part of me loves it. And so I do want to tell you about it. So the FAST stands for 5 years since reaction or less. The A is anaphylaxis or angioedema. The S is a severe cutaneous reaction. And the T is treatment required for reaction. So in pure PenFast, you would just get different numbers of points for these different things. You'd add them, and then you could decide what to use as your cutoff. The authors have proposed a cutoff of less than 3 should be low risk. I think that it really depends on who we're working with. I think that I recently did work with dentists, for example, and they'd like to use PenFasts. If you have any points for PenFast, you go to the allergist. Otherwise, the dentist could handle it. And I think that that's completely reasonable. A few points, this 5 or less years since reaction, it's not like 6 years is magically different than 5 years and that 5 years is magically different than 4. So it really is the time since reaction has been the predictor. Anaphylaxis or angioedema, if we're asking patients this or people who are not in the know, they need to know how to discuss anaphylaxis or angioedema with patients. Anaphylaxis is a technical term. Our patients don't often know it. But you might be able to say, oh, did you have hives and wheezing? And they say, yes, I did. And that was anaphylaxis. So we need to be able to lead them there. Severe cutaneous adverse reaction in the drug allergy practice parameters. This is a contraindication to challenge. So although it's nicer to have this S listed here, it's actually might be harmful in our discussions with our colleagues because we want them to identify severe cutaneous adverse reactions like Stevens-Johnson's and duress syndrome, but we don't want them to think about challenging it. And you only get 2 points in their rule for that. So I like to think of that as an exclusion to challenge and somebody that you need to see allergy, immunology, or dermatology. And then finally, treatment required for the reaction. In this study, treatment was pharmacologic treatment, so something like antihistamines or epinephrine. But we found in our studies in the US that actually it's more seeking medical attention. The emergency room might be a better factor than receiving medicines. Okay, so a few caveats, like I discussed, it performs really well at the extremes. So we can tell somebody who's really high risk and who's really low risk, but somewhere in the middle, it's very challenging. So we should really think about what we recommend our colleagues use for PenFast. If they're going to use PenFast, what they should use as a cutoff. We do need a higher sensitivities tool in that it picks up just 20% of the positives. And like I mentioned, SCAR is only a 2, but it's a contraindication. And so far, it has not worked in children. There's limited US validation, and there have been no studies in diverse patients. I will present this study, which is in press in 2024. This is with Mayo Clinic and Mass General data. And this is a prediction model too. And I present this just because as a sort of warning about adoption of PenFast before it's ready for our patients. PenFast performed right along this line. And this line is when a test is just as good as flipping a coin, so not so good. We were able to make a better prediction model. That's this one that's in the yellow-orange. And this was with using machine learning. But it's useful to just recognize that maybe data-driven prediction models are going to outperform our own clinical judgment, which can be sometimes random, but they might not all be ready for prime time. In this model, I wanted to show you our best model, that orange one. We were able to see that a few new factors requiring medical attention less than 1 year since the reaction and hives were drivers of having a confirmed allergy. So the way that you can see that there are drivers, let's look at hives. You can see how it sort of splits. The blues are here and the pinks are here. That showed you it was a driver and required medical attention. You can see how it even was better. The blues are here and the reds are here, really, or the pinks are there. It's really split. So those are factors that we found important in our own data. And I would like to draw your attention, I guess, to this 111 criteria that was a European criteria for hives, because hives has been underpowered in these prediction model studies. We don't know necessarily what makes somebody have high risk hives versus low risk hives. And so one study in Europe said that if your hives appear to follow this 111 criterion, that they might be higher risk. Okay. So we have, moving on to some key populations. These are key populations I would love to just introduce to you as to the idea that we need to spread penicillin allergy delabeling. This figure, the dark blue, shows places that we don't do delabeling. And then there are different colors by how much we are doing them. So of course, we have outpatient allergy clinics, we're doing the most penicillin allergy delabeling, then everything else is different colors. So we have a lot of work to do. Like I mentioned before, surgery is an area of importance because if you have a penicillin allergy label and you go to surgery, they want to use cephalosporin. And some of the best ways to use cephalosporin is to get rid of that penicillin allergy label. There's so many surgical and non-surgical procedures per year. And this is the recommended choice. And then all these other beta-lactams are recommended often as well. Now, cephalosporin administration in penicillin allergy is not complicated as much anymore because this study showed that there was a really, really low risk of cross-reactivity. This cross-reactivity risk in the cohort was less than 1%, which is often considered largely noise. There is a difference. If you self-report a penicillin allergy, your risk is 0.6%. But if you have a confirmed penicillin allergy, your risk is 3%. So that could be cross-reactivity, or it could be dual allergy, like multiple drug allergy, or just because you have one allergy, you might have a different allergy. Okay, so I want to move to the consensus-based statement here that is useful for thinking about cephalosporin. It says, we suggest for patients with an unverified non-anaphylactic penicillin allergy, a cephalosporin can be administered without testing or additional precautions. And the strength of the recommendation is conditional and the certainty of evidence is moderate. And then we suggest for patients with a history of anaphylaxis to penicillin, a non-cross-reactive cephalosporin can be administered without prior testing. So what does this mean for us? This means history of penicillin allergy, cephalosporin is different than penicillin. You don't need testing, even with a history of anaphylaxis. So this is amazing new news for all of our surgical and anesthesia colleagues, and also will take us a little while to get up to speed and make sure that we have confidence in this conditional recommendation. So I still prefer a drug challenge if there's time to do it preoperatively, especially if there is anaphylaxis. I think that we've done a number of studies where we've found that if you remove the penicillin allergy label before surgery, like 100% almost of the patients get cephalosporin. But if you leave it there, but tell them it's okay to use cephalosporin, they might not use it. So that was this group. So you can improve cephalosporin use 27-fold if you remove that penicillin allergy label before, but actually if you just tell them they can use it, we did a study where it was just twofold. So I think that it requires some work to get up to speed to encourage cefazolin use in penicillin allergy. Okay, I want to show you this best practice alert, which is another way to encourage referrals of penicillin allergy patients before surgery. This is one that was used by University of Iowa before orthopedic surgery. All right, and then to move to immunosuppressed populations, it's clear that these people are going to use antibiotics. And so a mean of 40% of days after bone marrow transplant have antibiotic exposure. There are things like neutropenic fever. There's a high burden of antibiotic allergy and beta-lactam allergy in all of these patients. So studies have shown that we should really be proactively assessing immunosuppressed patients. This is one study of just 59 cancer patients and looking at their after antibiotic allergy testing and showing that we can improve the change in antibiotics if we do testing versus not. This is sort of a pre-testing period, 12 months and 3 months, and the narrow spectrum beta-lactams. These are the guys we want them to use. And in fact, it increases from 13.9%, 14.8% before to 33.3% after. And then looking at these restricted antibiotics, these are the ones we want to decrease. If you test the immunosuppressed cancer patients, we go from 57.6%, 60.5% to 16.7%. Okay, a few more populations I want to drive home. Older adults. So my parents would be offended by the little man with the cane. But older adults we think of as our patients who are accessing healthcare more often. They're more likely to have immunosuppression. They're more likely to have multiple medicines. And then, so the drug allergy labels increase with increasing age. All right, and so also a higher prevalence of infections and adverse reactions can have more complications for patients when they're older. So we did one study where we looked at older adults and drug allergy evaluations, and we were able to delabel 96% of drug allergy evaluations in general. What this graph is like the total drug allergy evaluations is 486. 281 were penicillin, the remainder were not down here. And this big bar is all the people who were delabeled. And these tiny little things are people with immediate or delayed reactions that we identified. So overall, the big picture here is that we should be delabeling our older adults. All right, so finally, I'd like to move to how we improve the effectiveness of delabeling. So there are many things we can do to improve the effectiveness of penicillin allergy evaluation and delabeling. So the first is we have to increase our access. We have to spread to non-allergists. We have to think globally and also locally as far as our hospitals are concerned. We have to increase uptake. So sometimes we get to the hospital and to see a patient and they're totally not interested in evaluation. So we have to increase knowledge and uptake in our communities and our healthcare systems. We have to correct the documentation. So we have the tools to correct our documentation, but we have to spread that. So even those family history of allergy, or sometimes I go to evaluate somebody, they're like, I'm not sure if the allergy to penicillin was me or my twin sister. These are just incorrect documentations that we have to be able to encourage others to take care of so that we can do the testing as allergists. After testing, we have to use beta-lactams. So maybe after a delabeling, the patient or the clinicians are still nervous about using beta-lactams. And so we have to understand those barriers to encourage beta-lactam use. And then finally, once we've delabeled patients, unfortunately, that pesky label comes back. And we have to figure out how to prevent relabeling. Again, tools to correct this documentation. This is an interesting prevention of relabeling best practice alert that's from Texas, University of Texas Southwestern. And so they use this best practice alert to make sure that you don't re-enter a penicillin allergy after it was purposefully removed. So they actually had to create a system to catch us because people were re-entering. So this says an amoxicillin challenge with no reaction was previously documented and a penicillin allergy was added, please review. And so it sort of catches you and you say, oh, like I'm not just, this isn't an allergy I should add back without talking to the patient. And sometimes we're adding back allergies because of things like ethics care everywhere. All right, now about barriers and facilitators. So these are things that are important for when we're thinking about the patient in front of us and our communities. So many barriers exist to penicillin allergy delabeling. In this study, they found reluctance to discuss penicillin allergy, an abundance of other antibiotics, especially from the patients and the clinicians thinking, well, we have alternatives. Racially and ethnically minoritized people were deterred by past experiences with healthcare systems and not wanting to go get tested. There was clinician concern about harm. So having real robust systems in place and collaboration with allergists is important. Then there was clinician concern about clinic operational barriers, like how much delabeling could happen in primary care. And then there were facilitators for this, which is that patients were interested generally, clinicians wanted to use safe and effective antibiotics, and they wanted to improve their ability to do delabeling discussions. So this is what we learned from going into primary care clinics in Boston. These are a few quotes that I find somewhat interesting. So this is like a clinician interested in improving delabeling. It's like, why don't we make this something that we, friendly, approachable, something we consider normal, like we discuss safe sex. So with adolescents, once you practice it, just make a habit and you just do it. So this is almost like why when we see a patient in allergy clinic for asthma or rhinosinusitis, if they have a penicillin allergy label, we should just always also address this, because we're going to be encouraging our colleagues in primary care and others to also address it. And then finally, there was some inpatient qualitative study about the clinicians and their barriers and the facilitators, the barriers shown in these sort of this big dark red arrow down. And the little arrow that is the facilitator was that everyone, all the clinicians in the hospital think it's important, but they actually just don't have confidence in their skills. They're worried about hurting patients. There's no ownership. There are competing demands and space limitations. So we are up against a lot to be able to spread penicillin allergy evaluation and delabeling. This is my ending of looking at all the different concerns. So we have to think very globally about how to set up our colleagues and ourselves for success, thinking about training and education, thinking about the electronic health record, our health systems, innovations and research policy changes, and then finally the resources we need to do testing and to spread a group for testing. So thank you so much for your attention today. I am happy to take questions with our remaining time.
Well, thank you very much, Dr. Blumenthal. Really appreciate this very thorough presentation that you've done today. I do have a few questions for you from the audience. So when, let me see, can a history of a skin rash be considered benign? When can a history of a skin rash be considered benign versus something more severe or at risk for anaphylaxis?
This is a great question. I think that when we should consider it almost by default. So was it hives or non-hives is a good question. And was it a severe cutaneous adverse reaction or not? And so if it's a rash, but it didn't involve the mucosal space and it didn't involve organ involvement and the skin didn't all peel off, we know it's probably not a severe cutaneous adverse reaction. And then on the flip side, hives versus not, I use the same sort of definition of hives as sort of, I ask if it very, very itchy, raised off the skin, disappears within a few hours, or was it like a rash came on, it was slow moving? And if it's something that's like erythema, slow moving rash, morbilliform rash, then all of those I would consider benign rashes. And then if it's robust urticaria, this 111 criterion is like basically that the rash comes on within an hour, it recedes, so it comes on quickly, it recedes quickly, it appears after a dose. So those would be higher risk hives.
Okay, the same question, the person said, let me see, I can't read my own handwriting, bear with me. So does the classification, are teenagers considered adults or children for the purposes of dealing with this?
It's a good question. And I'd say that you could consider them probably with children because they were labeled as very young children and they still are pretty close to that. If the reaction were more recent, like within a few years, I would maybe test them more along the adult guidance, but I would definitely consider them children. It turns out like 3 in 4 of children who are labeled before age 3 with penicillin allergy. So it really is that most of this is very early on label, probably misdiagnosis for a viral rash.
Got it. Okay. Are patients with urticaria, and I think the question is coming from chronic urticaria, are patients with urticaria more likely to react to antibiotics resulting in, say, a rash? She was saying many PCPs will label this as an allergy.
Yeah, so I think that if the patient has underlying chronic urticaria, it's so important to almost retest all the medicines, because potentially all of these medicines are added to their allergy list when they actually had chronic urticaria and it had nothing to do with the medicines. It really is that chronic urticaria patients, when they have infections, are likely to flare of their chronic urticaria, not that the drug is causing a problem. So that's really important. So we often will get patients into remission with their chronic hives and then challenge, regardless of what medicines they're on, then stable, we would challenge to delabel different drug allergies at that time.
Okay. So somebody just asked, the first question I asked you about a history of skin rash, benign, would it make any difference if it was amoxicillin versus penicillin?
No. So the reason why sometimes we're really interested in the difference between was your reaction to amoxicillin versus penicillin is actually because some people are allergic to aminopenicillins. That means ampicillin and amoxicillin, because they share a similar side chain, and that actually has cross-reactivity to some of the cephalosporins that also share a similar side chain, like cefaclor, cephalexin, cefadroxil, cefprozil, those 4. And so sometimes it's important to know about what penicillin it was for that purpose. Also piperacillin or Zosyn, it's important because you could also be selectively allergic to piperacillin. But other than that, we should deal with all allergy history taking the same way. Rule out a severe cutaneous adverse reaction, and then try to distinguish between hives and morbilliform benign cutaneous eruptions.
Okay. Are there testing for other type of antibiotics such as clindamycin?
This is a great question. So our skin testing is not great in that we can do skin testing for immediate reactions for many, many drugs using what is called the non-irritating concentration. This is literally a concentration, a diluent that we have identified that when you put it on the skin, it doesn't cause a wheal and flare the way that like food allergy or a birch allergy testing would. But what we know is that just the penicillin is validated as a skin test, and where some of the others are pretty good, like cephalosporins are pretty good. But when it gets to clindamycin or the macrolides or other drugs, it's often a drug challenge that we need to do. We need to know whether or not the patient tolerates it, and the skin test can't really tell us that without clear diagnostic properties. It doesn't, like I showed you those many studies of the penicillin allergy diagnostic properties. We don't have that for any other drug.
Okay. Somebody in the audience asked, what is considered a severe cutaneous adverse reaction? I was wondering that too, because when my son, when he was little, of course he's an adult now, he had some ampicillin or amoxicillin, I think it was amoxicillin, and he had this hive on his back that was the size of his back. And so when you were explaining that, I was thinking, I wonder what that was.
Yeah, so a severe cutaneous adverse reaction, I think of, so it's the acronym SCAR, severe cutaneous adverse reaction. And the biggest ones are Stevens-Johnson syndrome, which is a rash that usually involves the mucous membrane. So inside the mouth, the vagina, the eyes, like, very, like very severe. Or toxic epidermal necrolysis is another one. Really when they heal, it heals with like, the skin really almost falls off, not just a fine peeling, the skin almost falls off. And then DRESS syndrome, where there's organ involvement, that's called drug reaction eosinophilia and systemic symptoms. That's when there is organ involvement, like the liver or the kidney are involved. And so those are the common ones that we have to think about. Now, sometimes these benign rashes can really be pretty ugly for the patient, and severe, like impactful. And that can impact delabeling too. So I've had patients that have technically a benign morbilliform eruption, but it was all over. They had to take steroids to get better, lots of antihistamines. They felt terrible. They had to miss work. They're not interested in doing this again. So I think that we have to meet our patients halfway, because some people, regardless of how benign it is, don't want to do it again. But we have to talk about the risks and benefits, because maybe then if there is an antibiotic need, then you're using things that are more likely to cause C. diff or not treat the infection well. And so risk benefit, maybe try it again and try to delabel again on, you know, a Friday without, when you don't have something important on a Saturday or Sunday.
Got it. When you were referring to older adults, do you have an age in mind?
Yes, that was 65 and up. That was the welcome to Medicare population, which is why I was telling you that most people, it's just older adults, non-geriatric, but yes, the 65 and up. High level of delabeling, and it's not always something that I'd love to get it be something that the welcome to Medicare physical exam says, oh, you also have these 3 allergy labels. Why don't we go see an allergist and get that evaluated?
Got it.
That's
Okay.
one of my dreams.
We have a lot of school nurses in the audience traditionally for these webinars. And so, you know, what if they have a student who has a penicillin allergy or an amoxicillin allergy, and then they're older, you know, they kind of go into their adulthood, like my son, for instance. I'd have to ask him to see if he ever got delabeled. So would you recommend that if somebody was labeled with one of these allergies as a child, that you consider getting them tested or whatever for delabeling?
Yes. Okay. So like if I were a school nurse and I had to give a kid like an antibiotic that wasn't amoxicillin or Keflex, I would probably try to pass along the information that once you have an allergy, it doesn't always stay. And that there's adverse like consequences of like being labeled and not confirming it. Because if you're, you know, if a kid's getting sick from like an ear infection or sinus infection, and they're using like a sulfa or Clinda or these other antibiotics, maybe they're doing that because of the allergy label. And maybe the family has no idea, and the pediatrician has no idea that that we can evaluate penicillin allergy and Keflex allergy. Really just try it again. Because those are the best medicines for most pediatric infections.
Okay, that's great. Well, you know what? It's 4:59. And so I just want to say thank you for this wonderful presentation. I want to thank you for being here, the audience as well. We really learned a lot today. Our next webinar is atopic dermatitis and skin of color. It'll be presented on February 20th by Dr. Kelly Maples. I hope you can join us for that. And as we mentioned already, you'll be receiving an email via Zoom within a few days with some links and some supplemental information about medicine allergy and delabeling of penicillin allergy. And so look for that. And thank you all for being here today and for joining us at Allergy and Asthma Network. Hope you'll be back. Good night, everybody. Thank you, Dr. Blumenthal.